have had this question several times, and I thought to make a video just to explain to you what the autonomy of a nurse on a step-down unit can look like. I have had people explain to me that they do not understand what it means by the nurse can take some certain decisions to a certain extent, or a nurse can suggest to the doctor what to do. So I'm going to explain to you a typical scenario of what I had last night, and I will kind of present the situation to you and let you know how I kind of reached out to the doctor to plead my case, or to make my own suggestions as to what we could do to help the patient. Hi guys, and welcome to my channel. So yesterday I had a typical scenario of a patient whom I had to present or kind of make a suggestion to the doctor, and I just came back from work and I just wanted to present this case to you guys, especially to those who have been asking me questions like, hey, can you explain elaborately what you mean by making suggestions to the doctor? So let me present this patient as was on my shift. So I'm going to be changing certain things just so that it don't get into HIPAA violation and get into trouble. So I'm going to change some certain things, but I'm going to make sure I stick to the medical diagnosis and prognosis of this patient so that you better understand what I meant, or how you can suggest to the doctor in terms of the patient's present condition, the patient's past medical history, and what the patient is currently coming up with. So patient came into the hospital with the EMS in the ED, and patient was found confused on the floor. Patient also had lateral lower extremity swelling or edema. When the patient got into the ED, the patient had AFib with RVR. AFib with RVR wasn't something new, because the patient also has a history of CHF, renal insufficiency, hypertension, diabetes, hyperlipidemia, AFib, and this patient is on digoxin at home, and the patient also has some arthritis. This is an elderly patient. The patient is 98 years old, quite elderly. Patient has not been urinating in the Foley. Patient is obviously oliguric, not necessarily anuric, because previous night the patient's output in the Foley was 70 for me. Day shift said the patient's Foley output was 120. Last night Foley output was 40 cc's for me. So again, remember that this patient has renal insufficiency as a history. Definitely some kidney issues is going on, but patient has edema because the patient has a history of CHF. So normally one of the things on assessment that you will find on a patient with CHF, maybe like shortness of breath, cough, most of the time will be edema. So this patient had bilateral lower +2 pitting edema. Day shift tells me that patient's blood pressures have been soft, but remember again that the patient is not even peeing. This patient was not on any fluids because of that CHF, and the patient, as I was told during day shift, the patient ate their food fine and finished everything on the tray. In a case like this, you would have to present everything about this patient to the doctor. So I tell the doctor, hey, this patient came in with some swellings to the feet. The patient is on Lasix IV 20. The patient's blood pressure has been soft. The patient doesn't have a cough. The patient is not on any continuous fluids. The patient eats fine per day shift that I was told. Patient is quite restless at this point. I would suggest that we reduce the Lasix from a 20 milligrams to a 10 milligrams, and maybe we give a bolus of maybe like 500, but running at 250 ml per hour. And we can recheck the blood pressure after that to see how things fare with the patient, and then we can urine analysis on this patient, a UA on the patient, to see like what is going on. Then I also mentioned, hey, the patient hasn't slept, like is there something you want us to do to try to give the patient some rest for tonight? So the doctor goes ahead and puts in an order for morphine, because sometimes morphine will knock some patients out. If you think about it, sometimes when you give patients pain medicine, they become drowsy, they become sedated, and definitely they tend to just fall asleep. So that was the thought process in giving that patient morphine. And the doctor started an IV antibiotics, Rocephin, just because the patient's pee was amber, smelly, and it was cloudy, which are already telltale signs of a UTI. Patient's mentation is just one. The patient can respond to their name, but they don't know where they are, they don't know what year it is, they don't know why they're in the hospital and all of that. So I'm explaining all of this to say I had to reach out to the doctor to say, hey, patient's blood pressure is soft or is on the low side, but patient is on Lasix because the patient has edema and because the patient has a history of CHF. Patient also has a history of renal insufficiency, which is making the patient to be oliguric or not peeing as much. And so it will make sense for us to give the patient fluid in a low rate so that it can bump up the patient's blood pressure, and it can also kind of hydrate the patient because the patient is not even peeing in the first place. Also, another big thing was it had AFib, which was a history of this patient, but again this patient was on digoxin back at home. So I hope that you've learned something from this. When it comes to the autonomy that nurses have, especially here in the US, I don't know how things are in Canada and other countries. You tend to marry the presenting condition, the patient's past medical history, and what is in front of you, and then you make suggestions surrounding this patient's diagnosis. If you notice, I had to mention that the patient had CHF. I had to mention that the patient had renal insufficiency. I had to mention that the patient's blood pressure was soft. I had to mention that the patient's mentation has changed and the patient needed to calm and sleep. So these were all things that I had to keep in mind so that I could make suggestions of, hey, the patient is on Lasix, can we cut that down? Because the patient needs that fluid in the legs out of the system. But again, we do not want as much Lasix that the patient was already on because it's going to drop the patient's blood pressure even lower. And would also want labs on this patient. I forgot to mention that. We also want labs on this patient because, hey, when you're giving the patient diuretics, whether Lasix, Bumex, you want to always make sure that you're monitoring the patient's potassium. So definitely labs were also ordered. And you also want to keep in mind that, hey, the patient's mentation in terms of what do you want to give the patient that is not going to trigger them to be even more confused. So everything was administered. It ended up that by the end of my shift, the patient still did not pee. So I had to pass that on to day shift. So lab results came back and the patient's electrolytes were so not good. Patient now had hypomagnesia, meaning the patient's magnesium had dropped. The patient's potassium was elevated to a 5.3. Labs were definitely an intervention for this patient. Antibiotics IV was an intervention for this patient. A bolus for blood pressure was an intervention for this patient. Reducing of the Lasix IV was an intervention and suggestion for this patient, as well as the morphine that had to kind of like calm the patient was also an intervention for this patient. So these were all suggestions that I had to make. So that is what I mean when I say the autonomy that we nurses have, and the kind of like the power we have to kind of suggest to doctors. So I hope that this video was elaborate. I hope that it was explanatory enough. I hope that it clarified your doubts. If you have any other questions, please shoot those questions to me and I will do well to answer them. I'm always so happy to answer these questions because I want to shed more light on what the step down unit is. Again, like I keep saying, that the step down unit is that unit that is one step away from the ICU. At any moment, the patient can go to the ICU, and at any moment that a patient is transferred from the ICU to the step down, that same patient can still go back to the ICU. That same shift, the next hour, the next 30 minutes, I have seen it, and so I can tell you that it is real. Thank you so much for stopping on to my channel. I hope that you do not stay a stranger. You stay family to us by joining this family. And from me to you, I'll see you guys in my next one. Bye guys.